I am going to first say that I think that the job you all do is incredible, and I think it's an incredibly complex job because having to convey to the patient what they're up against when they're facing surgery is an incredibly daunting task, because just the fear factor that surrounds them clouds their thoughts and their judgment. And in the exam room, we try to explain to the patient what they're going to undergo, why they're going to undergo it, what the goal is, what we can achieve, what we can't achieve. But it's in a very compressed moment where there's another patient in the next room. We need to hurry. There's always that compression of the moment which clouds the whole clarity of thought. And so when they see you, we're asking you to help explain what we have failed to do. And that is an incredibly hard task, because the patient is coming in to see you with great fear, great anxiety, confusion, and those are really difficult emotions to engage in a discussion with a patient. So I must share with you that I've never had a patient say the scheduler didn't achieve the goal of the discussion, which is incredible. I think you have really hard jobs, and it takes a lot of skill to be able to bridge the scientific knowledge of what the surgery is, what the surgery does, with the basic language of a patient who doesn't have the same level of knowledge that you may have. Our goal today will bring you a little more insight into the medical side, but sort of my goal is to bridge the eye from a scientific perspective to a practical side. And I'm going to show you in more practical terms how I see the eye, give you some analogies as to so as to make it more simple in terms of thought, and perhaps enhance your ability to understand exactly what the surgeries that our surgeons perform are trying to achieve. So when Aaron, you can start. I'm going to run through a few basic anatomy pieces first.
The sclera is the white portion of your eye, making up the back 5/6 of the eye's outer layer. The function of the sclera is to provide protection for your eye and to serve as the attachment for the extraocular muscles which move the eye.
I missed my cue, but the white part of the eye, I would say, think of the eye like a soccer ball, except with that, instead of having the hexagonal little, they're not squares, but yeah, exactly, the hexagonal hexagons, it's a rounded structure. It has, in some ways, the sclera, the white part of the eye, has in essence the texture of a thick soccer ball. Okay, it has that sort of thickness to it, but a sort of tautness to it. And so when we cut into it, it's as though it's put on stretch. You know, if you take a piece of, I don't know, anything, and you pull it apart and then you cut it, it kind of, the fibers fall apart. It has this fibrous kind of feeling as if you were trying to cut into a soccer ball that's really very inflated. Okay, so that's kind of that. Have you ever seen, anybody not seen a flag from flag football? Everybody know what a flag, raise your hand if you know what a flag from flag football is. Okay. The muscles are like the flags from flag football stuck on the outside of the soccer ball. Can you roll it back a little, Aaron, or no? We're not okay there. That's okay. So this is an example of one of the flags here. And so imagine you have a piece of Velcro and then you stick the flag on. There is in essence an attachment for the muscle here and each where it attaches. The muscles can be cut off, lifted, and put into different places. But think of the muscles as attaching to the eye like a flag from flag football, with a piece of the Velcro here and then the tail of it coming that way. And then imagine if you could move those flags, you could move the ball. So imagine if you put one at 3 and 9 and 6 and 12, and if you move those flags like a tether, you could move the eye. There are actually 6 muscles, 4 that are at 6, 12, 3, and 9, and they move the eye, as you would imagine, left and right, up and down. And then there are 2 other muscles, and I really can't reach. Do we have a pointer? No? that insert obliquely. So imagine if I took next time I'm going to bring a soccer ball. If this is the soccer ball, the regular muscles insert this way, or that way, or that way, or that way. So you can move the eye up or down, left or right. Imagine if I took a flag, though, and laid it on my hand like that, and I rotated this, and this flag could go this way. So there's one flag, we call it an oblique, that pulls this way, and it allows the eye to rotate in. And then there's one on the bottom of the eye that allows the eye to rotate out. So in addition to going up, down, puppet show. All right. In addition to going up and down, left and this is the closest I'm going to get to a workout. Okay. All right. Anyway. Okay. Anyway, in addition to going up and down, left and right, imagine again there is a flag that goes across the ball that can be pulled that way. And in essence, you can rotate in, which we call intort, or another one which goes oblique along the bottom and rotates out. So an eye can move up, down, left, right, and then in and out. And that intorsion and extorsion is important because look at me. Okay, everybody tilt your head to the right. You are using the muscles that intort the eye. And then if you bring your head the other way, without thinking, your brain is using your intorters and extorters to keep things straight ahead. If we didn't have those oblique muscles, when you moved your head, the whole world would be skewed. So without thinking, our brain moves the eyes through the movement of these 6 muscles, and these oblique muscles are as important as the 4, we call them cardinal muscles. Okay, next, you could run it, Aaron.
The cornea is the clear front window representing 1/6 of the outer layer of your eye. The primary function of the cornea is to focus and transmit light onto the retina.
So, to me, the cornea is like the crystal on a watch. Imagine if you get a watch and it has this big domed crystal. So when you look at the face of your watch, there's that piece of glass. That's what the cornea is. It's a big piece of crystal glass that covers the inside of the eye. And some watches have a sort of curved face. Some watches have a sort of flat face. Depending upon the steepness of the face, will determine how light is bent. Could you roll it back a tiny bit? There was the figure of light passing through. There, okay. So what you see is light hits the cornea. So all light comes at us parallel. Imagine 2 lines coming straight ahead. Imagine 2 cars coming at you. Both cars are on a straight path that if they were to drive forever, they would never collide and they'd never go away from each other. They would always stay, let's just say they're 2 feet apart. So light enters your eye like 2 cars coming straight ahead. Okay? And that's because light has the ability to be a wave of energy. When light hits the cornea, as you can see here, the cornea in this eye starts to bring the 2 cars together. So you can see here it starts to make a bend. Can you see that? So no matter where the light is coming at you, once it hits the cornea, it starts to bend towards each other. So these cars then start to slightly tilt their inner sides towards each other so that if they go far enough, they'll ultimately collide. Okay? When the light hits the lens, the brain has to make an assessment as to whether these 2 cars, which are now on a path towards each other, we want them to collide right here at the retina. What the lens does is it assesses how much they're approximating or converging, that's the word I wanted to use, and it then adds even more. So as the light hits the lens adds even more convergence or brings them closer together. So you've got 2 drivers driving straight ahead. When they hit the cornea, the driver of the outside car turns in, the driver of the other car, so both drivers turn their steering wheels in a little bit. So now as both cars continue to drive, instead of going straight, they're heading slightly towards each other. When those cars pass through the lens, they turn their wheels even more, So both drivers are now heading on a collision course where if they go far enough, the two cars will collide. The goal is for those two cars to collide right here on the retina. That makes sense? The cars are light that we see. The whole goal of the cornea and the lens is to move those steering wheels or those drivers so that those two cars crash right at the back of the eye. If either of these structures fails to turn the wheel enough, if either of these two structures fails to turn the wheel enough, these cars may not collide till further out in space, in which case you've gotten an eye that doesn't have the ability to move the light to converge close enough in space. The light travels further, in which case you could put another lens here that takes the light and starts to converge it sooner, so that these two structures finish the goal of converging the light here. Conversely, if either of these adds too much convergence, meaning they turn the wheel too much, these cars will collide here, in which case the light itself won't be able to reach the retina. We can take another lens, put it here, that causes these two cars to diverge or move away from each other a little, so that when they hit this structure and this structure, they gently come towards each other to collide here. So glasses, contacts are basically putting another lens to adjust the light so that in concert with the cornea and the lens, light comes to focus here. Refractive surgery can do one of two things. Okay, so our goal is to have these two cars collide right over there. So we can put a lens here to work in concert with these two, and you've got light focused on the retina. Or you could adjust how much this structure brings the lines together or how much this structure does. So refractive surgery involves, for example, LASIK, changing the shape of this structure so that it adds or fails to add enough convergence so that the two cars collide right there. If you can't operate on the cornea, you can operate on the lens, in which case you take a lens which adds how much convergence or divergence you need and put it right there. So the refractive surgeries involve either adjusting this or adjusting this or adjusting both. And in essence, what you're doing is taking two cars which are driving parallel to each other and encouraging them to collide right at the retina. Does that make sense? Does that make sense? Yeah.
If they collide before the retina, is that nearsighted or farsighted?
Okay. So if they collide before the retina, that is nearsighted. Okay? If they converge behind the retina, that's farsighted. That makes sense? So what we're doing when we're doing refractive surgery or doing glasses is we're either adding more convergence or more divergence. In essence, we're taking the wheels of the two cars and either turning them a little bit more in or a little more out. Both cars, when you turn the wheels, both turn in the same way, meaning you either turn them both in or both out. Okay? What's that? Great. Okay, next slide.
The conjunctiva is the thin, moist, clear membrane that covers the sclera, the white part of the eye. It is the skin that lines the eye socket and protects and lubricates the eyeball.
So imagine taking a piece of saran wrap. Imagine taking a piece of saran wrap and putting it on the outside of your soccer ball. Okay? So that saran wrap covers the white part of the soccer ball. In our example, to be true to form, I've taken the soccer ball, I've cut out the front of it, and I put on the crown of a giant watch. That makes sense? So imagine I take a gigantic watch, Okay. So I take a soccer ball, I cut out the front and put the crystal of a watch. So I've got 3/4 of a soccer ball with this clear glass front, these flags on the sides from flag football, and now I take a piece of saran wrap and put it on the outside of the ball. The saran wrap is your conjunctiva. That saran wrap can be lifted, it can be cut, it can be put down. And this is exactly what it looks like, and it goes all the way around the eye. This is connective tissue. This saran wrap exists on all muscle structures of the body. We call it fascia when it's in your leg. So all muscle groups are surrounded by this connective tissue. The reason it exists, most likely, is because the muscles on the eye need something to wrap them, and it just extends over the sclera as well. But again, we call this the conjunctiva. This is where a pterygium would be. So if you've ever seen a pterygium, just to add to the imagination, this layer of saran wrap has actually in the healthy eye has some blood vessels that grow through it. But these vessels are very small and you really can't see them. If you have ultraviolet damage over a period of years, either to the inner or outer part, this conjunctiva will thicken, just like skin will thicken with ultraviolet exposure, and you'll get a pterygium. So a pterygium is a thickening and a vascularization of the conjunctiva. And surgery to treat a pterygium is, in essence, cutting out the unhealthy or cosmetically unsightly conjunctiva and either leaving it bare, meaning the sclera, and let the conjunctiva heal on its own. Or if I have a pterygium here, I can cut out the piece of conjunctiva. I can go over here where there's healthy conjunctiva, cut out a piece. Imagine if I was going to patch a hole in my jeans. I get a piece of denim, so I go over here, cut out a piece of extra conjunctiva, remove the pterygium, and then sew this piece here. That's called a pterygium with a graft. So what you're actually doing is grafting healthy conjunctiva from a different area. And that is all you have with the pterygium, is a vascularization, a thickening, and in some cases a bit of a growth onto the cornea. But this is the layer of the pterygium. Any questions there? Yeah?
What determines if you're doing the graft or not?
Most surgical technique, surgeon preference. Where's Dr. Finneman when I need him? Surgeon preference. I think that most, and I don't know how Dr. Berlin does it, but I would imagine a majority of cases probably are accompanied by a graft. The thought is that a graft probably decreases the chance of a recurrence. Okay? The real problem with pterygium surgery, the joke amongst ophthalmologists is, when does a pterygium recur? The answer is on the table. The joke about it is, if you remove a pterygium, it starts to recur before you leave the operating room. So we don't know why, but recurrence of a pterygium is the biggest complication, for lack of a better term. And even if the patient's 30 and they took 30 years to get the pterygium, it doesn't take another 30 years to get it to regrow. It could regrow inside of a year. So putting a graft decreases the chance of regrowth because you've taken healthier tissue. That makes sense? Yeah?
What happens to the area where you took the tissue?
Right. Okay. So that's a great question. So this is generally on the periphery of our soccer ball, less vascularized to begin with, less exposed to the environment, and basically it will just fill in. So it will just regrow. It'll just regrow. It's not quite as pure as the initial or virgin conjunctiva, but the body will form another semi-membrane to replace what's been removed there. And it's not a problem. You don't. You leave it bare. So you actually just leave it bare. It meaning our soccer ball. So our sclera, our soccer ball, is left bare, and this layer will just kind of grow in. Some surgeons, when they remove the pterygium, just leave the sclera bare over there. The worry there, though, is that blood vessels will grow in from other areas and then create another pterygium pretty quickly. Okay, next slide.
The iris is the colored portion of your eye, located behind the cornea and in front of the crystalline lens. This structure separates the anterior and posterior chambers of the eye.
Imagine a fish tank. Imagine our analogy. Now we take our soccer ball and cut it in half. Just cut it in half, lift off the top piece. So I've got the top piece, the bottom piece, and then the crystal in the front. Does that make sense? So I take the top off. So I got a top piece, a bottom piece, just like the model in the exam rooms. You've got the top, the bottom, and that clear thing that keeps falling on the floor. Ultimately, you lose it. First you lose the lens, then the cornea, then the whole thing doesn't stay and it falls off the base. So you got the bottom, the top. Okay. Imagine if I took a partition. So imagine if you took any kind of structure and you just took a piece of, can I borrow your folder? Imagine if I took a partition, put it right in the middle of the eye. So right in the middle of the soccer ball, I dropped this partition in. So I've got two compartments, okay? In the another analogy, just to imagine if I took a fish tank and dropped a partition down the middle. I filled one side of the tank with water. I filled the other side with a lucite, clear kind of jello, and I let that jello harden. So you've got a watery substance in the front, a partition, and then you've got this gigantic jello mold in the back. The jello mold is the vitreous. The water is the aqueous humor. So you've taken your ball, put a partition in the middle. The partition is basically your iris and your lens. Here you've got this jello-like structure. Here you've got this water-like structure. Okay? Your jello-like structure is your vitreous. Your water-like structure is your aqueous. And you've got a clear-cut separation by your iris and your lens. Natural partition. Okay. Go ahead.
The function of the iris is to help regulate the amount of light that enters your eye. The crystalline lens is the transparent structure inside of the eye, located directly behind your iris. The sole function of your lens is to focus light rays onto the retina.
So your lens is held in place by these little strings, which we call zonules. The lens is most like an M&M with a coating on the outside and then chocolate on the inside. Cataract surgery, in essence, removes the front of the M&M, the coating, removes the chocolate, and then you place peanut butter in there. So you're, in essence, removing the chocolate, leaving the shell, and putting something in its place. And what you're putting in its place is, in essence, a lens, which at the moment is a plastic or acrylic or silicone structure, but most likely in the future will be a semi-solid substance that has the ability to move. And so in the long run, what would be nice to do is, instead of making a large opening in the M&M and scooping out all the chocolate and putting something else, what the goal will be is to puncture a small hole in the chocolate, take a tiny straw, suck out all of the chocolate without opening the candy coating, and then inject a liquid lens that becomes somewhat semi-solid, more viscous, so that you can maintain the outer capsule and, in essence, inject a liquid lens that functions far more like what you've removed, which is the chocolate. Okay, next slide.
The vitreous is a clear jelly-like substance that fills the center of the eye. It is composed mainly of water and comprises about 2/3 of the eye's volume. The vitreous helps the eye maintain a round shape and is attached to the retina at various points, including the macula and the optic nerve.
The vitreous serves one purpose, and that is not in the adult eye. The only reason humans have vitreous, because during embryologic life, when the baby is and the eye is developing, in order to develop or form a lens, we need a blood supply for the cells that ultimately form the lens to grow. So when the baby is developing and the eye is developing, an artery grows from here across the chamber to here, it connects here. It's like taking a water hose, except it connects to here, and the lens develops. Once the lens develops, this hose regresses and basically gets absorbed. The only reason you have the vitreous, though, is if you didn't have this viscous structure or substance, this hose needs a scaffold to grow on. And so if this is filled with liquid or with nothing, the hose wouldn't be able to crawl, or the blood vessel wouldn't be able to crawl across the eye and reach the lens. So the purpose of the vitreous is that embryologically, we need that blood supply to develop the lens. Once the child is born, the vitreous has no purpose in adult life. That's why it can be removed with a vitrectomy, because it doesn't serve anything other than perhaps providing some support. If it was vital, we wouldn't be able to do vitrectomies because we would be missing something. So the fact that you can remove the vitreous with vitrectomy without any negative implications to the eye shows you that the primary purpose of the vitreous was achieved in embryologic life before the baby is born. It doesn't have an adult life purpose. Okay.
The retina is the nerve layer that lines the back of your eye. The retina's function is to sense light and create impulses that are sent through the optic nerve and to the brain.
So the retina is like film of a camera. We take our soccer ball, we have saran wrap on the outside, that's our conjunctiva. We take film from a camera, old-fashioned film, and line the inside of the eye. And that's what the retina is. It's a photoreceptive film that captures images. Go ahead.
The macula is located roughly in the center of the retina. It is a small and highly sensitive part of the retina, responsible for detailed central vision. The fovea is the very center of the macula. The macula allows us to appreciate detail and perform tasks that require central vision, such as reading or driving a car. The optic nerve is located in the back of the eye. This structure is responsible for transmitting the images we see from the retina to the brain. The front surface of the optic nerve, which is visible on the retina, is called the optic disc.
What you see here is a fiber optic cable. It's the coalescence of 1.2 million fibers which transmit information from somewhere in the retina to somewhere in the brain. And in essence, it is a fiber optic bundle with roughly 1.2 million fibers. When the eye pressure is high, you're actually putting a backwards, like if I took my hand and pushed down. And if you push on these fibers, you crush them. And when you crush the fibers, you kill them. And when you kill the fibers, that's what we call glaucoma. So glaucoma is defined as damage to the nerve fibers because of a crushing force of eye pressure. And if we damage some of these fibers, we're losing our ability to transmit information from the eye to the brain. Okay, so in glaucoma, your eye can be healthy, your brain can be healthy, but if you've damaged some or all of these 1.2 million fibers, you've blocked transmission of the information from the eye to the brain where seeing occurs. You've all seen visual field tests done. Have you all seen the visual field? Maybe not. Yes, maybe. It's the test where the patient goes in the room and it's kind of like a video game. There's a bowl-like device that flashes lights and they push a button when they see the lights. It makes a map of their center and their periphery. In order for there to be an abnormality on that test, they need to lose at least half of these cells, meaning the visual field will be normal until they've lost at least 1/2 of all of their optic nerve cells. So a visual field is not a reliable indicator of early glaucoma. It is an indicator of a glaucoma that's somewhat advanced, but in the early part of the disease, when the first 500,000 or 600,000 cells are dying, that visual field test will be normal. In any case, we use the visual field as a way of knowing how the nerve is functioning. Okay?
There are millions of nerve fibers that pass through the retina and converge to form the optic nerve. When light hits the retina, it is converted into electrical impulses and carried along these fibers through the optic nerve and to the brain.
So the optic nerve is actually part of the brain.
Glaucoma is caused by a number of different eye diseases, which in most cases produce increased pressure within the eye. In an eye that has glaucoma, more fluid is produced than can be removed by the eye. With nowhere else to go, this fluid builds up in the front of the eye, causing an increase in pressure. Over time, this increase in pressure transfers to the rest of the eye.
So the drain, remember, in our model of the two compartments, here's our soccer ball, here's our partition, here's our watery half, here's our jello half. The watery half is constantly reproducing itself. So there's a faucet and a drain. The drain is a structure that actually goes all the way around the eye, and the drainage spaces can get blocked, leading to the scenario where the eye makes more fluid than it can drain. That pressure builds up in the front of the eye, but it ultimately gets forced backwards. Go ahead.
The optic nerve, the weakest area of the eye, is most vulnerable to damage from this elevated pressure. Continuous elevated pressure, or spikes in pressure, can damage the optic nerve, which may result in vision loss and can also lead to blindness if left untreated. Small specks or clouds moving in your field of vision are called floaters.
I want to move to looking into something that is hard to understand, which is the vitreous cavity and floaters. Floaters are incredibly common. Patients complain of all sorts of floaters. It's hard to know which floaters are worrisome and which are just someone complaining. So the first thing I want you to think about, if a patient says, you know, since I saw the doctor, I've developed floaters, the first question you want to ask is, which eye? If they go, I'm not sure, that's less of a problem. So floaters in one eye or the other worries me more than when they go, oh, I have floaters in both eyes. Floaters in both eyes, fortunately, doesn't generally suggest anything worrisome. When floaters suggest an eye problem, it's only going to occur in one eye at a time. So a patient that comes in with all of a sudden developing floaters in both eyes, it doesn't mean we don't pay attention to it, but our worry is much less, and I'll show you why. So the first question to ask when someone says, I've got floaters is it, which eye is it? And if they go, I'm not sure, that's already telling you it's less of a worrisome scenario. And if they go, I think it's both, even less of a concern.
Most floaters are not dangerous and are caused by tiny pieces of tissue inside of the eye. When light hits these pieces of tissue, it creates shadows on the retina.
So imagine if when we made our jello, this lucite colored jello, before it hardened, we dropped cornflakes in it. That's in essence what floaters are. They're opacities that are floating in this jello so that when light passes through them, they cast a shadow. So floaters are actually small opacities like cornflakes floating in this gelatinous matrix that when light passes through them, create a shadow.
That appear to float across your field of vision. It may appear that these specks are on the front surface of your eye, but they are actually inside. In most cases, floaters are no cause for alarm and no treatment is necessary. However, a sudden increase in new floaters may indicate a problem, and an eye examination is recommended if this occurs. As we age, the vitreous inside the eye tends to shrink and may eventually separate from the inside surface of the eye.
So I want to give you one more analogy for the vitreous. Imagine if we took our soccer ball and we took a sponge, like a gigantic, you know the sponge you used to wash your car? That big old sponge? And imagine if you cut it into a round shape and filled the inner surface of the eye. So in essence, instead of a Jell-O analogy, I'm using a giant sponge that's wet, and when it's wet, it fits perfectly on the inner back compartment. Does that make sense here? It looks kind of like a peanut here. See that? This is the vitreous. Now imagine with age, that giant sponge starts to dry out. So if you took a sponge that was this thick and put it out in the sun, over a few hours it would start to dry out and collapse on itself. A dry sponge is way smaller than a wet sponge. Would you agree? So in essence, what happens with age is this sponge starts to dry out, and as it dries out, it collapses on itself. Remember, the sponge is connected to the back of the eye, or connected to our film that we've lined the inside of the eye with, our retina. And as this Jell-O or sponge starts to contract on itself, you can see it pulls off of the back wall of the eye. But in certain areas, it may be more tightly attached. Can you see that? And if this piece ultimately pulls off, it can pull a small hole in the film or the retina, and I'll show you that. Go ahead, Aaron.
This is called a posterior vitreous detachment, or PVD. When the vitreous pulls free from the eye, it is often accompanied by flashes of light and the appearance of tiny black spots in the vision. In general, PVDs are not dangerous, but in certain cases they can lead to more serious conditions.
So, remember, the sponge is collapsing on itself. That's called a PVD, or a vitreous detachment, implying the vitreous is detaching from the retina. As the vitreous collapses on itself with age, remember, it doesn't have any purpose in the human life beyond birth. In any case, if it's pulling really hard and it's stuck here, it's going to pull our film off the inside surface of our soccer ball. And if it pulls that film off, we've got a retinal detachment. The only way to fix this would then be to go in with the vitrector, cut this attachment here, remove the vitreous, and then fill the eye with a host of substances like a gas or a silicone to push the retina back up against the wall of the eye. So a vitrectomy is used to remove this area of adhesion and to remove all the rest of the vitreous so it doesn't happen again. And then you fill this cavity, which no longer has the Jell-O or the sponge, with a heavier substance that allows the retina to be pushed back against the wall of the eye. And then once that substance dissolves, the retina will have scarred back into place, so it no longer needs the support of the structure. Sometimes when a retina detachment is fixed, it redetaches. What happens in that case is the vitreous was removed, a gel or a gas was put in the eye to kind of push that back up against there. Be like if I put wallpaper on the ceiling and then fill this room with a giant gas bubble so that the wallpaper was pushed up against the ceiling long enough for the glue to dry. Does that make sense? What if I put wallpaper on the ceiling, filled this room with a giant bubble, but the bubble dissolved before the wallpaper dried? The wallpaper would come straight back down. That's what happens when a patient has a redetachment. The wallpaper didn't have enough time to stick to the ceiling in this case before whatever we put in there dissolved. And when patients have a redetachment, often what will happen is they put silicone oil, which is super, super thick, and the silicone oil won't dissolve or go away until you remove it. So if I wanted to put wallpaper on the ceiling and I was worried that the glue wasn't going to dry in time, if I fill this room with silicone oil and put wallpaper on the ceiling, that wallpaper will stay there until I remove the silicone. And if I leave that silicone there for 3 months or 6 months, it is unlikely that the wallpaper will then come down. Does that make sense? So it enhances the ability of the wallpaper to be stuck to the wall before whatever you put in there to push it back dissolves. Okay, go ahead.
If left untreated, these conditions can lead to vision loss and may also lead to blindness. It is suggested that anyone with symptoms of a posterior vitreous detachment should have an eye examination immediately to make sure that a more serious problem is not present.
A retinal detachment occurs when the retina's layers separate. Any portion of the retina that is detached cannot send visual signals to the brain. If left untreated, retinal detachment can cause devastating damage to an individual's vision. Retinal detachment is considered an ocular emergency that requires immediate medical attention. Over the course of an individual's lifetime, the vitreous inside of the eye shrinks. As it continues to shrink, a portion of retinal tissue may stay attached to the vitreous, leading to a retinal tear.
Okay, so our previous analogy, can you roll it back a tiny bit, showed the vitreous actually pulled the retina off. That's one way it can cause a detachment. Another way, which is more common, is instead of the vitreous, as it collapses, pulling the whole retina off, it usually pulls a small tear, or what we call a horseshoe tear. See how this is just sort of a tear in the fabric there? And so when the retina specialists refer to a tear, what they're describing is the vitreous is collapsing on itself, it's tightly adherent to the retina surface, and instead of the vitreous pulling the whole wallpaper off, it made a small tear. The worry here, though, is that any fluid that's here can then go between the film and the sclera, pushing the wallpaper off. Does that make sense? So if I had a wall and the wallpaper, and then I filled the room with water, if I made a hole in the wallpaper so that the water in the room can dissect behind the wallpaper, I can billow the wallpaper off the wall. And in essence, the most common reason for a detachment is a small tear in the retina develops, and the fluids that are floating here, and there is some water in this space as well, dissects between the wallpaper and the wall itself, causing the wallpaper to dissect off of the wall itself. And then surgery here would be vitrectomy to remove all of this, and then in addition, they would use laser to solder this tear back down. Just like you'd use a soldering gun to solder something, they can use cautery or laser energy to solder around this tear so that, and often what they'll do is make several rows of scarring or cautery so that even if fluid gets into this tiny little space, it can't dissect any further through the retinal area. Go ahead.
If a tear forms in the retina, you may notice slight changes in your vision, such as flashes or floaters. This condition requires routine checkups with your eye care professional. If left untreated, retinal tears can lead to severe damage to your vision.
The most common form of age-related macular degeneration is called the dry form. This form of the disease affects up to 90% of AMD patients. In the early stages of dry AMD, tiny deposits called drusen start appearing within the retina.
So we're now going to magnify the retina. What we're looking at is the inside of the soccer ball, and we're actually looking at the film itself. And imagine if you could look at the film. If you're just looking at a film, we're actually looking at the film. So imagine if the film, which is super thin, can be looked at from front to back. This is the front of the film. This is the back of the film. Okay, so we've got important issues. These are retinal cells. This is a layer that separates the retina from a blood vessel layer called a choroid. So you've got the sclera here. You've got a layer of blood vessels and then a membrane, we call this Brooks membrane, this blue layer, and then you've got the retina. So here's your retina. Here's a membrane that separates blood vessels from the retina. So your retina, that film, has a very high metabolic demand. It needs lots of energy. The act of seeing requires a tremendous amount of blood in circulation, far more than your muscles or any other part of your body, because sight is such a self-regenerating event. It needs a vast blood supply. And you can't have blood in the retina itself because it would obscure vision. So what the body has done is taken a series of blood vessels which run past the retina, separated by this thin layer, so that when these retinal cells need energy, they get it through these blood vessels. So oxygen can cross this layer and sugars can cross this layer, so these cells can do what they need to do without these blood vessels growing into this space. What happens with the retina as it ages is this here, this is a waste product of these cells. In a healthy eye, this yellow glob of stuff is carried away by garbage men inside of our body. So when we're young, this yellow stuff, which is laid down every night, is actually taken away by a cleaning crew, so it doesn't accumulate. As the eye gets older, this cleaning crew loses the ability to remove it as quickly as it's deposited. These are called drusen, or these are just cellular waste products from normal functioning cells. The disease occurs because we've lost the ability to remove them as quickly as they're laid down. And the presence of these cells disrupts this blue layer. Okay? The problem with disrupting this blue layer, so right here, this is dry macular degeneration. Dry meaning the blood is on this side. The disease is limited right here to these little yellow blobs. These are protein deposits. Dry macular degeneration implies that you've got these protein deposits, but no movement of these blood vessels through this layer. Okay, so in dry macular degeneration, dry means no blood. The problem is if you leave these yellow globs there long enough, they will weaken this blue layer, and ultimately weakening the blue layer will allow these blood vessels to grow roots that come into this space, and these rootlets will then start to bleed. And when you've got bleeding here, and I'll show you that in a second, you've got wet macular degeneration. So dry can lead to wet. Okay, want to run it?
These drusen may be so insignificant that the patient has few, if any, outward symptoms and no vision loss. As dry AMD progresses, more disruptive drusen begin to appear. As the size and number of drusen increase, patients may begin to notice a small dark spot in their central vision, causing them problems while reading or driving at night. Drusen alone are not proof of macular degeneration, but they are an important warning sign. It is critical for patients to understand that as dry AMD progresses, it can turn into the more severe form called wet AMD. A less common but more serious form of age-related macular degeneration is called the wet form. This form of the disease affects about 10% of AMD patients. In the wet form of age-related macular degeneration, abnormal blood vessels begin to develop underneath the retina.
Okay, so remember, we've got the same problem that has started, meaning these yellow blobs are accumulating and we've lost the ability to clean them out. And as they stay there longer and longer, they cause weakening of the blue layer. And once you've got weakening of the blue layer, you get these abnormal blood vessels growing into that space. Can you see that? The problem with these little trees of blood vessels is they are not able to maintain their integrity, and they will ultimately rupture and bleed. So what's happening here is that these blood vessels are producing a chemical telling these blood vessels, hey, it's great over here, build more. So once you've got one vessel that has breached that blue layer, that vessel will create chemicals that tell other vessels, hey, come on in, the water's great. Okay? And that's a problem because once you get one, you get many. And this is where Avastin is used. What Avastin does is it shuts down this cell's ability to tell these that there's a good place to grow here. Avastin destroys this blood vessel's voice, for lack of a better term. This blood vessel speaks to these by producing chemicals. And these chemicals say, bring us more vessels. Avastin shuts off this chemical production. So once this vessel stops talking, and Avastin not only destroys its voice and kills it, this whole stalk will go away. Once this goes away, and this goes away, and this goes away, you'll be back to where you were with just these yellow clumps. And hopefully, by killing these 3 stalks, you won't grow more stalks. And so Avastin is used to destroy and silence the first vessels that grow there. And the reason they need the vessels, the Avastin or Lucentis repeatedly, is because these protein deposits are laid down all along this blue layer, other areas will try to grow blood vessels over time. And so every 6 or 4 or 8 weeks, you need more Lucentis or Avastin to stop these small vessels from growing. Because once you've got them started, it's hard to stop them. Does that make sense? So that's where Avastin can be helpful in trying to A, destroy, and B, stop these vessels from causing more vessels to grow that way.
These abnormal blood vessels are unusually delicate and may bleed or leak fluid. This fluid builds up beneath the retina, causing it to bulge or lift up from the back of the eye. The eye is damaged as a result, causing central vision to appear blurred, wavy, or distorted. Wet AMD can progress rapidly, leading to severe vision problems in the affected eye and causing permanent vision loss.
Probably the most devastating disease we see is with macular degeneration, because they lose this right here. It is very hard to do reading, walking, driving when you've lost this piece right here. So losing the macula is by far the most devastating in terms of diseases, because it causes us to not be able to do basic things. Look in the mirror, shave, dress, eat, drive, see our food, so on. So macular disease or macular degeneration has the most devastating effect on the patient's function over the quickest time, because it causes us to lose this central window of vision. Go ahead, Aaron.
Early diagnosis of wet AMD is critical. If caught early, treatment options exist which may delay or reduce damage to the eye and decrease the severity of vision loss. Anyone with diabetes is at risk of developing diabetic retinopathy. In its early stages, there may be little or no visual symptoms. Without early detection and treatment, diabetic retinopathy can permanently damage the retina.
Okay, so in diabetes, we have blood vessels that grow in the retina normally. In diabetes, the primary disease is that blood sugar accumulates in the vessels. The sugars cause the vessels to become weakened, and when the vessels are weakened, they bleed, and you can see that here, as well as leak proteins. These yellow blobs are proteins that are in your blood. If I took a tube of your blood and put it in a machine called a centrifuge which spins it, it would separate it into 2 layers. One looks like this red blood cell layer. The other looks like this yellow or straw-colored fluid. When this straw-colored or yellowish stuff, so if a blood vessel opens, this stuff will spill out, as well as this stuff. Does that make sense? So remember, all your blood is like 2 different substances, a red layer and a yellow layer just mixed together. And if I rupture a vessel, both will leak out. And what you have here are hemorrhages and exudates. In essence, the normal substance which runs through your veins just spills into the tissue. Right here is your macula. This is your peripheral retina. The goal in diabetes is to try to keep these yellow fluid from getting into the macula. Because if this yellowish fluid or blood gets into this central area, it will disrupt central vision. If we can keep this little area, the macula, free of both blood and this yellow stuff, the patient's vision will still be very good. So the goal of treatment is to stop these blood vessels from bleeding and leaking and stop them from getting anything into here. Go ahead.
It may produce symptoms that affect vision. These include mild blurriness in near or distance vision, floaters, and even the sudden loss of vision. If left untreated, it can cause severe vision loss and even blindness. Eye surgeons cannot reverse the damage caused by diabetic retinopathy, but if caught in time, modern treatment options may help slow its progression and prevent further vision loss. It is critical for patients with diabetes to be examined on a regular basis, even if they have not yet noticed any symptoms. If a patient experiences any significant change in their vision, they should contact their doctor for an immediate appointment, even if they recently had an examination.
So in diabetes, you have bleeding of the blood vessels into the retina. The treatment, as you saw in that video, was if you have bleeding in the retina, your best way to protect the eye is to destroy those blood vessels. The reason is because if you have abnormal blood vessel growth, just like in the example of macular degeneration, when you saw those abnormal blood vessels grow through the blue layer, you can have a similar process in diabetic eye disease. And once you have these abnormal trees of blood vessels growing, the problem becomes they produce chemicals that recruit more blood vessels. So the key to diabetic laser treatment is to destroy the blood vessels and to destroy the area of the retina that is getting blood from those abnormal and leaking blood vessels. And that is because dying retinal cells also create chemicals that cause more blood vessels to grow. It's like if a house is on fire, someone puts out their head in the window, head out the window and says, "Get us water." And you bring a hose to try to put out the fire, but the hose explodes inside the house. You have another kind of problem. So when an eye has damage from diabetic eye disease, the goal is to destroy all the abnormal blood vessels and all of the abnormal retinal tissue, because the abnormal retinal cells are causing the body to try to make more blood vessels. And what you want to do is stop the abnormal blood vessel growth. And that's because in both macular degeneration and in diabetic eye disease, new blood vessel growth, or what we call neovascularization, is more harmful than helpful. And again, that is why Avastin is used both in macular degeneration and diabetic eye disease, because the root cause of the real sight loss in both macular disease and diabetic disease is this growth of abnormal blood vessels which fail to achieve their goal, which is bring blood to the tissue, and then worsen things by rupturing and bleeding into the space. And in the case of diabetic eye disease, they can bleed into the vitreous cavity, giving you a vitreous temp. Run the last one for me, Aaron. The last one.
One form of diabetic retinopathy is called proliferative diabetic retinopathy, or PDR. PDR occurs when new and fragile blood vessels grow abnormally from the retina into the vitreous. This can result in bleeding, scarring, and contraction of the vitreous, which may lead to retinal detachment. PDR can cause severe vision problems, and it can even lead to blindness. It must be treated as soon as possible.
All right, so those are so we've covered several things. Any questions about the things we covered? So we covered macular degeneration, we covered the structures of the eye, we covered diabetic eye disease, we covered why we use Avastin, why we use a vitrectomy, how we repair a detachment. What questions can I answer about any of the concepts we talked about? Yes?
Okay, I understand vitrectomies, but when they do an order, they say membrane peel. You
Okay.
didn't say anything about membrane peel.
Gotcha, okay. If you could go back for me, Aaron, to the retina. Just roll back the last one. I'll be happy to answer that. So imagine in our analogy, you've got the inside of the volleyball, inside of the soccer ball.
Proliferative diabetic retinopathy, or PDR.
Okay, go ahead, keep running.
PDR occurs when new and fragile blood vessels grow abnormally from the retina into the vitreous. This can
Pause.
result in
Okay. This isn't the best picture, but he's coming to get me. Imagine if, in our example, you have the inside of the soccer ball, and then you have a film that we lay down on the inside surface. That's our retina. What can happen is, imagine a piece of saran wrap developing on top of the film. So you've got the inside of the soccer ball, then this wallpaper, which is the retina, then you've got a piece of saran wrap that actually grows on the surface of the wallpaper. And this saran wrap has the propensity to kind of crinkle up. And as it crinkles, it pulls on the macular surface. So for some reason in some patients, the vitreous leaves a small saran wrap piece lying on top of the macula. So you've got like saran wrap on top of your wallpaper. And membrane is taking that saran wrap off to get back to the normal wallpaper. Does that make sense? And they use basically a small pick or forceps to actually grab this tiny saran wrap membrane that grows. It's also called cellophane maculopathy. It's like a piece of cellophane. And for some reason, the body has the propensity to develop these small cellophane membranes on top of the wallpaper. And they pick those away, and that's a membrane peel. Okay, any other questions? Yes?
Is there any preventative measures that you can do to prevent the drusen from building up?
So antioxidants. So the key thing there is blueberries, anything that has antioxidant ability. So you want to eliminate the oxidative stress. So the biggest oxidative stress probably is cigarette smoking has a big oxidant event. So eliminating or minimizing cigarette smoking, and then a diet rich in antioxidants over the course of a long period of time is your best defense. That makes sense? So that's the key. That's why vitamins are thought to play a role in minimizing advancement of the disease. Vitamins have this antioxidant propensity or ability to get rid of what we call free radicals. And it appears as though there's a cycle. The more of these free radicals you have, the more likely you are to lay down these proteins and the more damaging they are to the tissue.